Madam, we are live now. Shall we start?
Yeah, fine.
So good evening, doctors and all the participants. Shuman on behalf of Shield Healthcare, welcome you all in today's session on myths and facts on polycystic ovarian syndrome. And our guest speaker is Dr. Manjusha Saladi, madam. It's our honor to introduce Madam Rita MBBS, MS OBG, FMAS and FMG. Madam is a consultant obstetrician and gynecologist, laparoscopic surgeon, MS Multi-Speciality Hospital, Pithapuram. So with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation. And please drop your queries on the chat box of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, for your valuable time and for such an important topic on PCOS. So thank you very much, and over to you for further proceedings.
Yeah, good evening, one and all. Thank you, Shield, for giving me this opportunity. So just give me a second. I'll start sharing my screen. Is my screen visible?
Yes, ma'am.
Okay, shall I start?
Sure, madam.
Yeah, I'm Dr. Manjusha, consultant obstetrician gynecologist at MS Hospital. Today's topic of discussion is a very important topic which we deal in day-to-day practice, that is myths and facts on PCOS. This PCOS prevalence has been increasing day by day, and we see quite a lot of patients from different age groups presenting to our OPD with this PCOS. Actually, to tell this, we have two extremes of patients. That is, some are completely unaware of unaware that they are suffering from PCOS, and they totally lack the information. Whereas we see other extreme of patients where they flood us with lot of questions, where they have heard through their friends, or they've gone through internet or certain other media. They bring us lot of questions. Many of them are myths which we want to enlighten them. That's not the correct one, and so we should have an idea of this PCOS, and we should burst all the myths surrounding this PCOS. As a gynecologist, we should do that. This polycystic ovarian syndrome is the most common endocrine disorder in the reproductive age group of the females, and 1 in every 10 women suffer from this PCOS. And as we already seen that majority of the patients don't know that they have been suffering from this syndrome. Although PCOS is associated with hyperandrogenism and infertility early in life, it is a harbinger of a lifelong condition that can lead to serious sequelae such as diabetes mellitus, hyperlipidemia, endometrial hyperplasia or carcinoma, central obesity, sleep apnea, and even non-alcoholic fatty liver disease have also been associated with this PCOS. It is not merely a reproductive disorder, but an endocrinological disorder affecting women in their reproductive years. We can see that this PCOS, it is aptly coined as epigenetic disorder. That is, it begins in utero. That is, the woman suffers from it beginning in the utero, but it comes to the tip, it comes to the surface through different age groups when they come to us. So although hyperandrogenism and infertility, PCOS cause distressing, in addition to hyperandrogenism and infertility, the metabolic sequelae eventually they make the individual suffer a lot in terms of morbidity and mortality. So it is very crucial to diagnose PCOS early in its course so that we can decrease the symptoms and improve the quality of the life of the patients. And also it is imperative not only to recognize it, but also to delay or arrest its metabolic sequelae. Additionally, screening for the expected complications may allow for proper and timely management of these conditions. So why should these physicians know about this PCOS? Because as we all know that, different terminologies are being used now, like PCOS, PCOD, PCOM, PCOS. But I feel that PCOS is apt to use because it is a syndrome. It is a cluster of many symptoms and signs which are heterogeneously expressed in different individuals. One patient comes with some menstrual irregularity. The other patient comes with predominant hyperandrogenic features. So they have got different expression in different individuals based upon the genetic and environmental factors. So the PCOS, the term PCOS should be aptly used. Whereas this PCOM is polycystic ovarian morphology, that we see the number of follicles we count, and this scan criteria can be termed as PCOM. The diagnosis, why physicians should know about this PCOS is that the individuals are at increased risk of infertility, dysfunctional uterine bleeding, endometrial carcinoma, obesity, obstructive sleep apnea, type 2 diabetes, dyslipidemia, hypertension, possibly cardiovascular disease, and her sisters, daughters, and other close family relatives may also be risk, as we have already seen that it is a genetic disorder. She may require lifelong therapy and find that her access to healthcare coverage is well covered. Coming to the history of this PCOS, originally it was described by Steen and Leventhal in 1935. Historically, it is seen as a repair to disorder characterized by classically these three are the hallmark of this PCOS, that is oligo and amenorrhea, hirsutism, and polycystic ovarian morphology. It has been shown that when bilateral wedge resection of the enlarged ovaries was done, it normalized the menses and fertility of the women. So it is described as polycystic ovarian disease. And 30 years ago, it was first reported that women with PCOS had hyperinsulinemia. This is very important and is a path-breaking discovery, because this hyperinsulinemia is the key of this complex disorder, and it is an integral part of this PCOS, which is leading to many pathogenesis. The research indicated that PCOS was associated with a unique disorder of insulin action as well as a defects in insulin secretion, and together these abnormalities conferred a substantially increased risk of glucose intolerance. When coming to the epidemiology of this PCOS, we have already seen that it is the most common endocrine disorder affecting the reproductive age group. It is seen in about 8 to 11% of reproductive age group women, and it is the most common cause of anovulatory infertility in women, which contributes to about 70 to 80%. Indians have amongst the highest prevalence rate in the world, that is 41% in the reproductive age group. PCOS has become epidemic in India, and our India has lately became this PCOS capital of the world. 41 prevalence, there are about 117 million patients suffering from this PCOS, and the count has been rising. And 1 in every 5 women have been suffering from this PCOS. We can see these complications of PCOD. The primary infertility was reported in 50% of women, and secondary infertility was seen in 25%. There's 3 times higher risk of preeclampsia and gestational diabetes mellitus, and 2-fold increase in preterm deliveries, and 2-fold increase in risk of fetal growth restriction. And the metabolic sequelae, we can see like 2-fold increase in risk of myocardial infarction, 2-fold increased risk of hypertension, 5 to 10-fold increased risk in developing type 2 diabetes mellitus. There is increased risk of endometrial hyperplasia and cancer. And the psychological complications need to be addressed right now. There is 4-fold greater odds of depressive symptoms, high prevalence of anxiety disorders, and there is definitely reduced quality of life attributed to this PCOS. Coming to the definition of PCOS, there is no universally accepted definition for this PCOS. 1990 US National Institute of Health Consensus Conference outlines 2 minimal criteria, that is menstrual irregularity due to oligo or anovulation, or clinical or biochemical signs of hyperandrogenism, that is hirsutism, acne, male pattern baldness, or elevated serum androgen levels, above not attributable to other causes. So we can highlight these points, that is no laboratory evidence is required for the diagnosis. So there is no single test that tells us she is suffering from PCOS, and that is not at all required. this total testosterone levels, they're not at all indicated. It can be done to see the level of hyperandrogenism, but it is not clearly required for the diagnosis, and no radiological evidence required for the diagnosis. Ovarian appearance is not at all pathognomic. Insulin resistance is also not included in diagnostic criteria. These excludes women with other known causes of hyperandrogenism. It is a diagnosis of exclusion, and there is vast clinical heterogeneity, as we already seen. The 2003 ESHRE ASRM Rotterdam Consensus on PCOS has given these criteria. Minimum 2 out of these 3 criteria should be present to label as PCOS. That is oligo and or anovulation, hyperandrogenism, whether it is clinical and or biochemical, and polycystic ovaries with exclusion of other etiologies. So what is the radiological appearance? Previously, it is taken as greater than 12 follicles or the ovarian volume greater than 10 ml. But because of this high sensitivity probes now we are using, if we take this criteria, this PCOS is now overestimated. So we can see that we can take the count as 19 to 25 follicles in each ovary can be considered as polycystic ovarian morphology. Now coming to our topic, the myths and facts associated with this PCOS. In fact, this discussion is helps us. We all know these myths and facts as doctors and treating gynecologists, but they help us to enlighten our patients so that the myths are burst. Myth 1: all women with PCOS have ovarian cysts. This common question we face in our OPD. The patient will get a scan done outside and come to our OPD saying that, "Ma'am, I've been diagnosed with this polycystic ovarian cyst. So how many cysts are there for me? What is the size of the cyst? What treatment should be taken? And will cysts go? Will cysts go away? Please, please, ma'am, what should we do?" So I want to highlight the fact that according to the as the name states, there are no cysts. Okay, they're only the multiple follicles which we refer to as polycystic ovaries in this. So many people think that PCOS refer to cysts, but this is false. For many women, tiny follicles are present in the ovary and may resemble a strand of pearls on an ultrasound. The follicles may look like small cysts, but they're very, very different. These follicles are not cancerous and do not cause pain. Not all women diagnosed with PCOS have follicles on their ovaries. So myth 2, women diagnosed with PCOS can't have children. So this one also a common question faced by us. Some parents or mother-in-law which bring the patient saying that my daughter-in-law is somewhat diagnosed with PCOS. Will she able to bear kids? Is treatment possible and all? But I want to make clear that, of course, PCOS is a common cause of infertility in some women, but that doesn't mean that carrying a pregnancy to term is impossible. Many women with PCOS can conceive on their own or with the help of fertility treatments. Lifestyle changes and a healthier diet can also improve the chance of their conceiving. The myth 3, an irregular menstrual cycle means you have PCOS. If the cycles are irregular, they think that they have PCOS without any consulting anyone. But this is a major myth because other causes of irregular cycle should be ruled out. It is one of the major cause of irregular menstrual cycle, but there are also many other reasons. Typical cycles range between 21 to 35 days. Other factors such as stress, thyroid disorders, or other endocrine conditions, fibroids, or extreme dieting, we see in athletes, and conditions like anorexia, bulimia can also lead to an irregular cycle. If your cycle is irregular, please come to us and speak to a doctor. Additional tests and exams can be performed, which will identify the cause. Now, myth 4, women with PCOS can't lose weight. We can see that majority of the women with PCOS are obese. So they think that they attribute, when we say in the OPD that please lose weight, they go on saying that, "Ma'am, I have PCOS, like I have some hypothyroidism, so it's very impossible for me to lose weight." No, this is a major myth. Weight loss may be harder for women with PCOS, but it's not impossible. Many women with PCOS have a lower sensitivity to insulin, a hormone that regulates sugar in the blood. This is known as insulin resistance, which is a risk factor for many metabolic disorders like type 2 diabetes mellitus. And it makes it difficult to lose weight even if you're following a healthy lifestyle. But working with a registered dietitian and endocrinologist can also help with weight loss goals. Myth 5, all women with PCOS experience unwanted hair growth. This unwanted hair growth, which is referred to as hirsutism, is nothing but excessive growth of male pattern of hair that may appear on a woman's face, back, chest, abdomen, or thighs. Hirsutism is usually an underlying sign of PCOS or another endocrine condition, but it's important to remember not every woman will have this symptom. Other factors such as ethnicity can increase the likelihood of a woman having excessive hair growth. The myth 6, you need an ultrasound to be diagnosed with PCOS. We have already seen that ultrasound diagnostic criteria is not at all necessary. You need not have an ultrasound if you have criteria 1 and 2, that is this irregular anovulation or irregular cycles and clinical or biochemical signs of hyperandrogenism. In women younger than 20 years, we usually don't do ultrasounds. This means that irregular periods and hyperandrogenism need to be present for the diagnosis of PCOS to be made without any radiological sign. Myth 7, if you're not looking to get pregnant, you don't have to worry about PCOS. This is a very important myth because majority of the patients feel like PCOS is there, we'll land in infertility. So if the childbearing is complete, we need not worry about this PCOS. It's very, very wrong because whenever the diagnosis of PCOS is made, we will instill some drugs so that long-term sequelae of this metabolic effects are mitigated. So PCOS does not just affect a woman's fertility, it can impact her long-term wellness for the rest of her life. It has been linked to type 2 diabetes. More than half of PCOS women have diabetes or pre-diabetes before the age of 40. High blood pressure, hypertension, poor cholesterol levels, sleep apnea, depression, anxiety, and endometrial cancer. Getting diagnosed and starting right away treatment is very critical for a woman's health future. Myth 8, everyone with PCOS is obese or overweight. This is another myth because when we tell the patients who are very lean that you are being diagnosed with PCOS, they keep a strange look that I'm lean and why PCOS? So this is a misconception that you have to be stereotypically overweight woman. It's the image of the bearded fat lady. That is very false. The thing is, because PCOS is a syndrome, it affects people in many different ways. Therefore, lean PCOS women do exist. 30% PCOS is seen in lean people. Thin women might commonly be overlooked, and obese women with irregular periods might be inaccurately diagnosed with PCOS. So we should, as a clinicians, we should keep in mind always that overweight PCOS women should not be overdiagnosed, and underweight, this lean women should not be overlooked for this PCOS. Myth 9, insulin resistance in PCOS causes weight gain. The reality is that experts aren't sure why women with PCOS are often overweight. Many people say it's because of the insulin resistance, but while weight gain causes insulin resistance, and insulin resistance doesn't cause weight gain. But I feel like telling that it is a vicious cycle, this obesity leading to insulin resistance, weight gain, which in turn exacerbates the metabolic sequelae of this PCOS. So it goes on like a vicious cycle. Myth 10, women with PCOS should go on the birth control pill. Hormonal birth control pill is a common way doctors treat the menstrual irregularities of the PCOS. But the treatment for PCOS will largely depend on your end goal. So our treatment for the treating of patients of this PCOS is mainly tailored according to their needs. If they're adolescents, if they suffer with some acne, hirsutism, we give a medication according to that. And if they suffer from irregular cycles, apart from the main lifestyle management and all, we advise some hormonal pills to get their cycles regularized. And if they are going to look for any fertility options, we give ovulation induction. And so our treatment is purely tailored according to the patient needs. Not all the time patients will be put under birth control pill. Rather, we encourage them to address their hormonal health more holistically with lifestyle measures like reducing stress and eating anti-inflammatory diet, etc. Coming to the diagnosis of this PCOS, in 1990, we already dealt with it. The features of both should be present, clinical and or biochemical hyperandrogenism, along with oligo or chronic anovulation. 2003, ESHRE ASRM Rotterdam consensus two of the three criteria should be present: oligo or chronic anovulation, clinical and or biochemical hyperandrogenism, polycystic ovarian morphology. And in 2006, this Androgen Excess Society states that patients should demonstrate both hirsutism and or hyperandrogenemia, oligo anovulation and or polycystic ovaries. Now, coming to the etiopathogenesis of PCOS, till now, no theory has been stated like this is the causative factor of PCOS. So there are various theories put forward, and the PCOS, we should understand that low-grade chronic inflammation is the key pathogenic factor in this PCOS. We've already seen that we can say this PCOS is nothing but genetically determined ovarian pathology characterized by this hyperandrogenism, depending on manifesting heterogeneously in different individuals according to their genetic, environmental makeup. Okay, so this genetics, lifestyle, etc. lead to hormonal changes, which is exaggerated by the obesity, and these lead to low-grade chronic inflammation, which lead to hyperandrogenism and also insulin resistance. This insulin resistance is the key of this complex process, which lead to all these clinical symptoms like hirsutism, acne, oligoanovulation, menstrual irregularity, subfertility, metabolic syndrome, impaired glucose tolerance, increased cardiovascular risk factors. And nowadays, this important psychological issue have been overlooked, but we have to deal with, we should carefully look into it and deal with the psychosocial issues also, because most commonly in the adolescents will be presenting to us with this body image disparity and acne, hirsutism, make them lower the self-esteem. So they will be backgroundly, they will be dealing with the psychosocial issues also. So there will be more depression and anxiety also will be more in this PCOS patients. So we should address that as a gynecologist, where we are diagnosing them and we are treating them. So when we come to this slide, this PCOS can come to surface, though it is though it starts in utero and the woman suffers throughout her life. There are various stages. So spectrum from, we can see the spectrum of this PCOS from childhood to post-menopause. The predisposing factors, we already said, genetics, in utero programming, and we have seen that some studies have shown that increased exposure to maternal androgens during intrauterine life have also been implicated in the pathogenesis of this etiogenesis of this PCOS. There are different theories why they're exposed to more androgens. That is, some theories are like decreased placental aromatase activity, etc. So in childhood or pre-pubertal years, there is increased AMH levels in this PCOS persons, and in puberty there's premature adenarche hyperandrogenism, increased GnRH pulse frequency, increased AMH levels, ovarian volume, hyperinsulinemia, and irregular cycles. We can see that this acne, increased ovarian volume, irregular menstrual cycles, insulin resistance of puberty is also seen in non-PCOS ones. But in reproductive areas, we can see that there is decreasing androgen levels with age in these non-PCOS phenotypes, and decreasing AMH, ovarian reserve, and androgen follicle count with age. Whereas in PCOS individuals, there's increased AMH, androgen follicular count, and ovarian volume, the glucose intolerance, and insulin resistance. In postmenopausal also, we can see increased prevalence of hypertension and increased triglycerides. Some controversy is there, because in non-PCOS also, in postmenopausal years, due to their age-related risk, there is increased cardiovascular risk. These should be properly followed up and they should be compared. Now coming to these phenotypes of PCOS, we have 4 different types of PCOS: phenotype A, phenotype B, phenotype C, and phenotype D. In this phenotype A, it is fully blown PCOS. The hyperandrogenism and hirsutism, ovulatory dysfunction, and polycystic ovarian morphology, all 3 are present. And this is the most common type of phenotype regularly we encounter, which constitutes to about 67% of all PCOS. And in phenotype B, it is referred, we have this hyperandrogenism and hirsutism and ovulatory dysfunction. It is referred to as non-PCO PCOS, that is polycystic ovarian morphology, that is radiological appearance need not be present, is not present. Phenotype C, when we see, there is hyperandrogenism and hirsutism and polycystic ovarian morphology, but ovulatory dysfunction is absent. That is, they have normal regular cycles. So it is referred to as ovulatory type of PCOS. Now coming to phenotype D, hyperandrogenism and hirsutism are absent. Ovulatory dysfunction and polycystic ovarian morphology is present. So this is referred to as non-hyperandrogenic PCOS, which constitutes only about 3.6% of all PCOS. So what do we understand from this slide is that hyperandrogenism is present in majority of the PCOS and is a key sign to be dealt with us. So coming to the adolescent PCOS, as we all know, it is often diagnosed in adolescents. In utero exposure to fetal testosterone, hyperglycemia and hyperinsulinemia determine PCOS phenotype. Family history of PCOS, overweight or low birth weight, exposure to androgens during gestation, precocious puberty, obesity, insulin resistance, these are all risk factors of this PCOS. Diagnosis of PCOS during adolescence requires stricter criteria. So we should see that stricter criteria are applied for diagnosing PCOS in adolescents, because it is very, very important for us to say that to label an adolescent as PCOS. But when we keep the doubt, if it's not so, their emotional turmoil is very great. So if we are confident, and only we should term them as PCOS. This requires two features, that is unequivocal hyperandrogenism, that is, which includes two, that is moderate to severe hirsutism, and clinical and biochemical increased testosterone level should be there, and ovulatory dysfunction which persists 2 years after menarche. As we all know that during menarche and 2 years post menarche, the hypothalamic pituitary ovarian axis is quite immature and there will be irregular cycles. So if this ovulatory dysfunction persists even after 2 years of menarche, then we can keep it in mind, and these two should be there to label the adolescent as PCOS. Coming to, I'm not dealing with this PCOS and reproductive age group because it's a vast topic. PCOS in postmenopausal women, it persists with hyperandrogenism even after menopausal transition. They continue to manifest metabolic alterations and metabolic syndrome. Postmenopausal women with PCOS during the reproductive areas may still have manifestations of the syndrome, and there increased risk of the cardiovascular disease. Coming to this, we've already seen this, genetics, lifestyle, they lead to hormonal changes and obesity. The PCOS leads to, no doubt PCOS leads to this long-term metabolic sequelae, but if the PCOS woman is obese, they're more prone to this metabolic sequelae. Increased by these various mechanisms, increased androgens, increased insulin, which lead to increased androgen production from the ovaries, and they lead to hirsutism, acne, menstrual disturbances, and increased cardiovascular risk. When we see this slide, the epidemiological link, we can see alarming percentages coming up. The PCOD increases the risk of type 2 diabetes mellitus by 1,600%, and PCOD increases the risk of gestational diabetes mellitus by more than 200%. And we know that 60% of GDM patients may land in type 2 diabetes mellitus, and insulin resistance is present in 65 to 80% of PCOD cases. So we should understand that even though the lean patients, lean PCOS, will also have this insulin resistance, which is the pathognomic and responsible for all the pathogenesis, low-grade inflammation of the PCOS. We have already seen this, the pathophysiology. The key factors are insulin resistance and chronic low-grade inflammation. We can see this insulin resistance lead to many various ways. They control LH levels. Insulin is primarily responsible for controlling LH, control androgen. It mediates androgen production in theca cells. Insulin resistance coexists in PCOD. The patients have decreased the sensitivity to circulating insulin irrespective of weight, thus suggesting that insulin sensitivity is intrinsic to PCOS. Inositol deficiency drives PCOD. The insulin resistance seems to be driven by deficiency of myo and D-chiroinositol, the isomers of inositol. Insulin signaling is damaged in PCOD, and insulin dysfunction disrupts LH-FSH pathways and results in hyperandrogenism. Coming to the evolution of PCOD, we have seen that genetic factors, environmental factors, these all lead to inositol deficiency, which lead to deranged insulin signaling, which in turn lead to pituitary dysfunction, enhanced ovarian androgen production, and development of insulin resistance. The clinical features, the irregular menses, infertility, metabolic effects like increased insulin resistance, obesity, increased chance of type 2 diabetes mellitus, acanthosis nigricans, and androgenic effects like alopecia, hirsutism, and acne. Hyperinsulinemia can be diagnosed. Insulin levels may be increased in majority of patients with PCOS. A ratio of fasting glucose to fasting insulin is simple and effective. A ratio of less than 7 suggests of hyperinsulinic state. A fasting serum insulin level greater than 15. Serum insulin level post 75 grams glucose load of greater than 25. These represent the hyperinsulinemic status. Coming to the treatment should be holistic, and we have already seen that it should be tailored according to the patient's complaints, patient age of presentation, and what patient needs. So whether to mitigate their long-term metabolic sequelae, or whether to regularize the menses, or whether to deal with the hyperandrogenic effects of this PCOS. So we should tailor the treatment according to their needs. So undoubtedly, lifestyle modification plays a very major important role, and it works wonders in patients of PCOS. The PCOS is the mother of all lifestyle disorders. So improvement in lifestyle does wonders in this PCOS patients. Whenever a patient comes to our OPD and asks that how to treat PCOS, what is the treatment, what is the plan, I will tell them, I think we all tell them that 80%, 70 to 80% of treatment of PCOS is just in your hands. Only 20 to 30% I will help by this so that I can keep this inositols or metformin or some other adjuvant treatment. But 80%, the major treatment is in the lifestyle management. And mostly the adolescents will be coming to us. So as a gynecologist, we have to motivate them to eat healthy, It's very important. Many of the adolescents will not have any orientation to their diet. They eat whatever they want, and junk food, they incorporate junk foods, very, very unhygienic diets they follow. And this is a central, the food center also lead to inflammation, which lead to this PCOS and all. And obese patients, weight loss and change in diet and physical activity are very much recommended. Even 5 to 7% of weight loss has shown wonders, regularizing the cycles and all. This weight loss decreases serum insulin, androgen levels, and reduces the risk of glucose intolerance and type 2 diabetes mellitus. Pharmacological interventions in the presence of insulin resistance or glucose intolerance or dyslipidemia that persists after lifestyle modifications we can consider. So what are all drugs we come in this? We are treating. We should remember that many common question we face while sitting in OPD is when we are, what is the cure? What is the cure of this PCOS? There is no cure. Please make sure that to explain to your patients that there is no cure for PCOS. We only decrease the symptoms and improve the quality of life, and we help to prevent them from their long-term metabolic sequelae developing. There is no cure for PCOS. Okay. So hormone imbalance, we have different agents here. Insulin sensitizers like metformin, pioglitazone. There are a lot of controversies regarding this metformin. This metformin is definitely recommended according to this recent evidence by International PCOS Society, that if the BMI is greater than 25 in overweight individuals, we can recommend this metformin. The usual dose is 500 milligrams thrice daily or 850 milligrams twice daily. We can increase the dose by 500 milligrams every week or every 2 weeks. And this metformin has also proven to induce ovulation, help in ovulation induction in clomiphene citrate resistant cases. And metformin has also, according to RCOG guidelines, metformin has also shown to decrease this OHSS, risk of ovarian hyperstimulation syndrome. And we have anti-androgens, but metformin, one thing is sure that a lot of studies have proved that metformin does not decrease the weight or any waist circumference. So metformin has no role in decreasing the weight. And there are other agents like anti-androgens, spironolactone, cyproterone acetate, flutamide, finasteride, which can be prescribed to deal with this androgenic side effects like hirsutism, acne, baldness, etc. And the OC pills are there for regularization of the menstrual periods. Always, it's better to use low dose, low estrogen containing pills. The ideal one is ethinyl estradiol and levonorgestrel. And according to the specific symptoms mitigation, we can add other progestins. And when the patient wants conception, we can go for ovulation induction through drugs like clomiphene citrate, letrozole, anastrozole, etc. And if the hirsutism can be graded by this Ferriman-Galway scoring. And if this is more and it causes more concern to the patient, she can be advised to go for laser hair removal. And if this obesity, morbidly obese individuals, we can suggest bariatric surgery. And this acne therapy can also be done by local benzoyl peroxide, local retinoids, local antibiotics. But it's better to get them deal with dermatologists. And other strategies were also there, like laparoscopic ovarian drilling and statins in case of increased triglycerides levels. Managing menstrual disturbances. If you don't wish to conceive, medical therapy for interruption of estrogen is given to mitigate this long-term effect of endometrial hyperplasia and carcinoma. Non-fluctuating estradiol in the absence of progesterone cause irregular uterine bleeding, amenorrhea, infertility, and increased risk of endometrial cancer. OC pills elevate risks for this cardiovascular disease, dyslipidemia, and thromboembolic events. Therefore, we should meticulously use. Not all patients require OC pills. So first line, always we advise them that we keep on telling them lifestyle modification, please change your diet. The goal should always be smart goal should be developed. It's very important. Specific, measurable, achievable, realistic time goal setting should be done. And the patient should be advised to self-monitor whether what she's eating, what goal she's keeping in terms of her weight reduction, whether she's achieving within that period of time, and whether the goal is realistic. Like losing some 10 kgs weight in 1 month, it's not possible. So realistic goal setting should be done. Coming to this topic on inositol in PCOS, inositol, the insulin receptor resides in the cell membrane. When its B subunit is phosphorylated by insulin, insulin receptor substrates are activated. P13K docks to the insulin receptor substrates, which then leads to phosphorylation of phosphatidylinositol, eventuating in insulin action. Thereby, this isomers of inositol, that is myoinositol, increases insulin sensitivity by making more phosphatidylinositol available. So we can simply say that this inositol is a insulin sensitizing agent. Both myoinositol and D-chiro-inositol levels are very low in PCOS patients compared to normal subjects. So one pharmacological intervention in this PCOS patients is we can supplement them with this myo and D-chiro-inositol combination. How much dose should be given? It is always advised in 40:1 ratio. That is, myoinositol should be given when 2 grams. This D-chiro should be given as 50 mg. And the maximum dose of inositol for proper effect is we can give up to 4 grams per day. And when we see this effect of myoinositol, when given in the ratio of 40:1, they normalize insulin signaling and glucose metabolism. So insulin resistance diminishes. The reduced inflammation of ovarian theca cells and the androgen levels come down to normal levels. Thereby, fertility is restored. And LH levels also come down to physiological levels. The menses becomes normal. When the insulin levels also become normal, weight loss obviously starts. So these are the studies according to Cochrane review that inositol favors the live birth rate in PCOS. So coming to the conclusion, PCOS is a multifaceted condition. A multidisciplinary approach for evaluation of subfertility and ovulation should be done. A holistic care to increase success rate of fertility treatments. Lifestyle modification is very, very essential. Diet, exercise. The adolescent should be advised about 30 to 40 minutes of exercise per day. The exercise also other benefits like the endorphins which release during exercise may also elevate their anxiety, mood elevations, depression. So exercise is very important, and behavioral therapy are principal treatments. Low-dose gonadotropins can be used as first-line agent when affordability and acceptability are not major issues. And IVF are indicated in some individuals where along with PCOS, there are other factors like tubal occlusion or male factor. With this, I would like to conclude this session on myths and facts of PCOS.
Thank you very much, madam, for this nice talk on this emerging topic PCOS. Just give me 1 minute time, ma'am, to check if any question is there.
Okay.
Madam, one question is, what will be your approach in treating this PCOS in obese PCOS and lean PCOS patients? What will be the difference? Means how will you can manage?
Yeah, obese patients are very easy to treat, because when we ask them to, easy to treat means when they lose weight, they become more responsive to treatment, even if planning for ovulation induction or so. Actually, lean PCOS is difficult to treat. So obesity, first line, we will ask them, first line of therapy, we'll ask them to go for lifestyle modification. We advise them to lose weight. Lean PCOS, we have the other options like inositols, and according to their what they need, whether they're going for, they're looking for fertility options, or whether they're going for regularization of cycles, accordingly we will treat.
Okay, thank you very much, ma'am. And one question is, ma'am, in your practical experience, how frequent this ovarian drilling or this kind of surgical interventions will be needed for this PCOS, or what scenario or clinical aspects you prefer?
No, actually ovarian drilling, very few cases, only in very few selected criteria only we go, like when they are resistant to every drug like clomiphene, letrozole, gonadotropins, and it is also based on certain factors like their AMH levels. Then only we advise. Not all we go for ovarian drilling, and that we reserve for the last.
Yeah, sure. Thank you very much, ma'am. And apart from this lifestyle modification, is there any other approach in the first attempt you used to give your patient?
Along with lifestyle modification, I routinely keep this myo and D-chiro-inositol, because they are proven to reduce the inflammation, which is the hallmark of this PCOS, and the patients are quite comfortable with it, and the effect is good.
So thank you very much, madam. And what is your personal experience on this myo-inositol in PCOS?
Yeah, regularly as the dose, it's 40:1 ratio we keep, and in some obese patients and all, we go for 4 grams of myo-inositol per day, and the result has been good. Even in this adolescent PCOS, where the cycles are to be regularized, we keep along with OC pills, low dose OC pills. Not only they favor this metabolic effects, but also they reduce the negative effects of OC pills too. And in people going for ovulation induction, for fertility treatments also, I'll routinely advise this myo and D-chiro-inositol.
Thank you very much, ma'am, for this nice deliberation. So, ma'am, I could not find any other question right now. If you get any, then we will obviously forward it to your mail ID. So thank you very much, madam, for your valuable time on our platform and to discuss this important topic, PCOS, which is regularly faced by today's women, and the effect of this myo-inositol, obviously, how it is effective, how it is helpful in case of this PCOS. So thank you very much, ma'am, for in-depth discussion on this emerging topic. And in future also, we will look forward for some valuable session with you, madam. So thank you once again for your valuable time on our platform, Shield Connect.
Thank you for giving me this opportunity.
Thank you very much, ma'am.